This video demonstrates percutaneous tracheostomy techniques for intubated patients requiring a prolonged airway or those on mechanical ventilation. A tracheostomy creates a surgical airway maintained by a breathing or tracheostomy tube. This tube is inserted directly into the trachea through a neck incision. The tracheostomy procedure can be performed using an open surgical technique or a percutaneous dilation technique, either in the operating room or at the patient's bedside. Open surgery involves dissecting the anterior pretracheal tissue and inserting the tube into the trachea under direct vision. The percutaneous technique, on the other hand, allows for quick and safe bedside procedures, utilizing a modified Seldinger technique with bronchoscopic guidance. This method generally results in fewer bleeding complications compared to open tracheostomy, with similar long-term outcomes. Tracheostomy should be considered for patients with acute respiratory failure needing prolonged mechanical ventilation, typically 7 days or more, who are expected to recover meaningfully. It reduces sedation needs and aids ventilator weaning. Other reasons include upper airway obstruction, like vocal cord paralysis, airway protection for conditions such as neurologic disease or traumatic brain injury, and improved pulmonary hygiene, encompassing recruitment maneuvers and secretion clearance. Previous neck surgery or tracheostomy isn't a contraindication. Indeed, percutaneous tracheostomy might be preferred when surgical planes are distorted. Absolute contraindications include cervical instability, uncontrolled coagulopathy, and infection at the insertion site. Relative contraindications involve difficult anatomy, such as in short necks, morbid obesity, minimal neck extension, or tracheal deviation, and severe respiratory disease that prevents tolerating apnea or loss of positive pressure ventilation. Percutaneous tracheostomy procedures involve neuromuscular paralysis to minimize coughing and periods of apnea when the ventilator circuit is open. This requires specialized teams to minimize personnel and full personal protective equipment, or PPE. For bedside tracheostomy, you'll need sedation and paralysis medications, a flexible bronchoscope, ideally a video bronchoscope for visualization, a ventilator bronchoscope attachment, silicone lubricant for bronchoscope passage, saline, surgical lubricant, a dissecting tool like tonsil forceps or curved hemostat, a tracheostomy tube and collar, and a percutaneous tracheostomy kit. A kit typically includes a number 15 scalpel blade, introducer needle, guide wire, small tracheal dilator, protective sheath, single-stage progressive dilator, tracheal loading trocar, and a small slip-tip syringe. Choose a tracheostomy tube size appropriate for the patient. Kits are designed for specialized tubes that load onto a dilator. However, in practice, any tracheostomy tube can be inserted percutaneously. We favor thin, flexible tubes to maximize airway diameter and minimize tracheal wall pressure. For safe percutaneous tracheostomy, at least 3 people are needed: a bedside surgeon, a bronchoscopist, and a respiratory therapist. This is considered an aerosol-generating procedure. All personnel must wear PPE, following your institution's guidelines for such procedures. Position the patient supine. A shoulder roll under the scapula can extend the neck and improve anterior neck exposure. Support the head with a towel or small pillow if needed. Adjust the bed height for surgeon comfort. Ensure each team member is positioned for safe, effective, and efficient procedures. The respiratory therapist should be at the head, controlling the airway and ventilator. Position the bronchoscopist at the patient's left, near the bronchoscopy cart and monitor. The surgeon should be on the patient's right, viewing the bronchoscopy monitor. Left-handed surgeons may prefer the opposite. Palpate the neck to identify key landmarks. These include the thyroid cartilage, cricoid cartilage, and sternal notch. The ideal tube placement is between the second and third tracheal rings. Check for a high-riding innominate artery over the planned incision. Perform an open tracheostomy if a high-riding innominate artery is present. Before starting, conduct a pre-procedure timeout to verify patient identity and procedure. After the timeout, have the nurse administer a short-acting paralytic and, if needed, additional sedation. Inadequate paralysis risks inadvertent extubation during oral endotracheal tube manipulation. The nurse should then leave the room to minimize exposure but remain available. Sterilize and drape the anterior neck, ensuring easy access to the oral endotracheal tube. Next, make a 2 to 3 centimeter vertical neck incision directly over the trachea below the cricoid cartilage. Bluntly dissect pretracheal tissue until the trachea is palpable. In patients on therapeutic anticoagulation or at bleeding risk, consider placing a purse string suture around the incision using 2-O-Proline. Place, but don't tie. The purse string suture at this stage, tie it later for hemostatic control after tube insertion. Remove the suture on the second postoperative day if there's no bleeding. Don't suture the tracheostomy tube itself. This can cause skin ulceration and doesn't prevent decannulation. Next, ask the respiratory therapist to induce apnea by placing the ventilator on standby. Then, disconnect the oral endotracheal tube from the ventilator circuit and attach a bronchoscope adapter. Insert the bronchoscope into the adapter, reconnect the circuit, and resume ventilation. Advance the bronchoscope into the airway. Briefly survey the trachea and clear any obstructing secretions. Once everyone's ready, advance the bronchoscope into the oral endotracheal tube until the camera aligns with the tube's end. The respiratory therapist should then induce apnea again. Next, the respiratory therapist deflates the oral endotracheal tube cuff. The therapist and bronchoscopist then slowly withdraw the tube and bronchoscope together until subglottic landmarks are visible. Surgeon palpation of the anterior trachea can aid in landmark identification. Keep the bronchoscope inside the oral endotracheal tube to ensure airway control. Precise communication and coordinated movements between the therapist and bronchoscopist are crucial to prevent accidental extubation. Once the tube is withdrawn to the appropriate location, perform the tracheostomy using the Seldinger technique. Insert the introducer needle through the anterior tracheal wall under direct bronchoscopic visualization. Insert the needle around the second tracheal ring perpendicular to the trachea, with the bevel down. This bevel position helps direct the guide wire distally. Avoid damaging the oral endotracheal tube balloon. If the patient becomes unstable or tracheostomy is difficult with the intact balloon, advance the tube to its original position and resume normal ventilation. Gather additional supplies or personnel. If the balloon is compromised, positive pressure ventilation is lost. Establish a new airway quickly via tracheostomy or oral endotracheal intubation with an intact tube. Feed the guide wire through the needle and visualize it while advancing it distally toward the carina. Remove the needle over the wire, keeping the wire in the trachea. Advance a small tracheal dilator over the wire to dilate the tract. Remove the small dilator and advance a single-stage progressive dilator over the wire with the protective sheath loaded. Remove the progressive dilator, keeping the wire and sheath in place. Then, insert an appropriately sized tracheostomy tube into the trachea over the wire and sheath. If using a flexible tube, insert it with the curve toward the patient's head. Once you see the tube in the trachea, rotate it 180 degrees to its normal orientation. This prevents pretracheal plane creation. Alternatively, load a non-flexible tube onto an insertion trocar and advance it over the wire and sheath into the trachea. Remove the sheath, wire, and trocar if used. Inflate the tracheostomy cuff, connect the circuit, and resume ventilation. End-tidal carbon dioxide confirms airway placement. Alternatively, reinsert the bronchoscope through the tracheostomy tube to visually confirm placement. Once placement is confirmed, secure the tube with a collar. If a purse string suture was placed, tie it down to close the incision. Once the patient is ventilated through the secured tube, remove the oral endotracheal tube. In the immediate postoperative period, the tracheal stoma requires regular assessment and wound management, including frequent cleaning and dressing changes. Pulmonary hygiene, ventilator weaning, and decannulation should follow institutional guidelines and patient status. Stoma maturation occurs after about 7 days, after which the tube may be exchanged or downsized as needed. Early complications include bleeding, obstruction, and tube dislodgement. Bleeding is most common, but usually self-limited or controlled with pressure. If obstruction can't be cleared with suctioning, or the tube dislodges, secure the airway via oral tracheal intubation instead of attempting to insert a new tube through an immature tract. Late complications include tracheonominate fistula, tracheoesophageal fistula, and tracheal stenosis. Fistulas are rare and require surgical consultation. Percutaneous tracheostomy can be safely performed at the bedside for patients needing prolonged mechanical ventilation. To learn more about this and other critical care procedures, please visit www.ecgkid.com. Don't forget to like and subscribe for more educational content. Thank you.